Fluid is stacking up in the space around the lung, and every single millimeter steals a breath. Welcome to this explainer where we're turning the absolute essential NCLEX facts about pleural effusion into a fast-paced, highly visual whiteboard session so you can completely crush your exam. I am so excited to guide you through this today because pleural effusion is honestly one of those high-yield respiratory topics that you are guaranteed to see on the floor and for sure on your boards. We're going to build this concept piece by piece right here so everything just clicks into place.
Picture this, a rising tide right inside the pleural cavity. Normally, the pleural space is supposed to have just a tiny, microscopic layer of lubrication. But when that delicate balance breaks, fluid accumulates, pressing the lungs smaller and smaller. The patient's lung is literally being restricted from expanding. That is, until a thoracentesis needle finally goes in and draws that fluid off, allowing the lung to beautifully re-expand.
Okay, let's kick things off with pathophysiology and the two main causes.
So the causes of this fluid buildup are split right down the middle into two main camps, transudative and exudative. Transudative is basically a systemic pressure issue. Think of heart failure, which by the way is actually the #1 cause overall. Pressure backs up in the system, or maybe there's too little protein like in cirrhosis, and a clear, watery fluid is physically pushed into the pleural space. Exudative, on the other hand, means localized inflammation. Think pneumonia, tuberculosis, or a tumor. The blood vessels get leaky from all that inflammation, and they spill a cloudy, protein and cell-rich fluid right into the space.
Now, providers use something called Light's criteria to figure out exactly what kind of fluid we're dealing with once they draw it out. You definitely don't need to memorize the complex math for the NCLEX, but you do need to understand the trend. If the ratio of pleural protein to serum protein is high, like greater than 0.5, or if LDH is greater than 0.6, you're looking at an exudate. Basically, if there's a bunch of extra stuff in the fluid, it's an exudate. Simple as that.
Moving on to signs and symptoms, spotting the danger.
The absolute crucial point here is that as fluid replaces air, your patient is going to show immediate respiratory distress. Dyspnea, or shortness of breath, is your glaring, bright red warning sign. Alongside that, they might complain of sharp pleuritic chest pain and a dry cough. But the physical exam, that's where you really make your money. If you tap over that fluid, it won't sound hollow like a healthy lung, it's going to sound like a dull thud. If you listen with your stethoscope, breath sounds will be decreased or even completely absent over the fluid line. And if you feel for vibrations when they speak, which is called fremitus, it will be decreased, simply because fluid blocks those vibrations from getting through.
Burn this memory trick into your brain right now. Fluid equals dull and down. I'm telling you, this phrase is a guaranteed point on your boards. If a test question describes a patient with dullness to percussion, down or decreased breath sounds, and down or decreased fremitus, they are practically screaming at you that there's a fluid collection in that chest. Next up, let's talk about priority thoracentesis nursing actions. Let's see how all of this builds into your actual clinical workflow. These 4 steps are your primary nursing priorities, and they happen in chronological order. Remember, your ABCs. First, support their breathing. Put them in high fowlers and get some oxygen on them to relieve that compression-related hypoxia. Second, assist with proper positioning for the actual needle insertion. Third, you've got to closely monitor the exact amount of fluid being removed. And fourth, conduct a really rigorous post-procedure assessment to make absolutely sure we didn't cause a brand new problem while trying to fix the old one.
Let's zoom in on step 2 for a second. This specific positioning is incredibly critical. Why? Because it physically widens the intercostal spaces and allows gravity to pull the fluid down to settle at the base of the pleural cavity. This keeps the sharp needle safely away from the healthy lung tissue. You want the patient sitting upright, leaning comfortably forward over a bedside table with their arms resting right on it. And make sure you tell them to hold absolutely still, and whatever they do, refrain from coughing while that needle is in.
And regarding step 3, you literally cannot forget this number. You must limit fluid removal to about 1 to 1.5 liters at a single time. I know it's super tempting to just drain it all at once to give the patient instant relief, but if you do, you risk severely shocking their system. Pulling too much fluid too quickly causes a massive, dangerous shift in hemodynamics. All right, let's get into the scary stuff. Red flags and complications.
Remember how I said you can't drain it too quickly? Well, if you drain that fluid way too fast, or pull way more than that 1.5 liter limit, blood rushes back into the newly expanded lung tissue way too aggressively. This creates a life-threatening complication called re-expansion pulmonary edema. If your patient suddenly starts coughing up pink frothy sputum and their oxygen stats plummet right after the procedure, this is exactly what's going down.
Your other major do not miss red flag is a pneumothorax.
This happens when the needle accidentally punctures the lung itself, leaking air straight into that pleural space. You'll catch this instantly if you're doing your post-procedure vitals and suddenly hear absent breath sounds on the exact side you just tapped, accompanied by new worsening dyspnea. This means you need an urgent post-procedure chest x-ray to confirm, and they're likely going to need a chest tube to resolve it.
Time for a quick NCLEX Test Yourself quiz. Let's see what you remember.
Question 1. A client is scheduled for a thoracentesis. How should the nurse position the client for the procedure? Read the question carefully, lock your answer in your minds, or drop it in the comments right now, and let's see if you absorbed the key takeaway for procedural safety.
Here are your options. Is it A, supine with arms at the sides, B, sitting upright leaning forward over a bedside table, C, prone with head turned, or D, left lateral recumbent? 3, 2, 1.
Excellent job if you chose B. The sit and lean position is the absolute gold standard here. It widens those intercostal spaces and prevents a lung puncture. Gravity is your best friend during this procedure, pulling the fluid down to the base for easy, completely safe access. Moving straight to our second high-stakes question. Think back to the major red flags we just covered regarding post-procedure monitoring. Question 2. Immediately after a thoracentesis, which finding requires urgent attention?
Drop your final guess in the comments. Is it A, relief of dyspnea, B, sudden sharp chest pain and shortness of breath, C, small amount of clear fluid removed, or D, mild puncture site soreness? 3, 2, 1.
If you locked in B, you nailed it. You correctly identified the classic signs of an accidental pneumothorax, proving you know exactly how to keep your patient safe. Look, relief of dyspnea is the actual goal, right? And mild soreness is totally expected. But sudden sharp pain and new shortness of breath, that means the needle nicked the lung and air is now escaping. You need to call the provider and get that stat chest x-ray.
So, as you head into your exam, ask yourself, are you fully ready to catch the silent rising tide before it compromises your patient's next breath? Remember the golden rules. Fluid equals dull and down, sit and lean to tap, and always, always watch out for that post-procedure pneumothorax. Master Pleural Effusion, tap it, watch for pneumo. If this made it click, subscribe. One killer Med-Surg topic every day until you pass the NCLEX.